Okay, so this video is the second one that I'm doing that's kind of on a very focused issue today. I kind of ran across this yesterday while I was in Facebook jail and I was doing all the other Farrakhan feminism shit, which you should also check out. But this was actually, I found it on a friend's feed who happens to be a pharmacist. And it is very interesting. And it kind of it indicates why it's so hard to be a small pharmacy owner or even a pharmacist now. You know, if you work for one of these big chain pharmacies nowadays, you don't get paid very well, and that's pretty unfortunate given how long it takes to get to go through pharmacy school and everything. I think I have a couple friends who are pharmacists. But in any case, this comes from fairly close to me. This is the Columbus Dispatch in, obviously Columbus, Ohio. And so CVS accused of using Medicaid rolls in Ohio to push out competition. So CVS Pharmacy, they're pretty huge. They actually made headlines, I think, last year for banning all tobacco products from their stores. So they do have a lot of policies that I think are, health directed, towards encouraging good health. But in this case, I think we're seeing like a problem with how they treat their competition. And in some cases, they have a little leg up on their competition. Let me explain. It says pharmacy giant CVS stands accused of overcharging Ohio taxpayers millions in an attempt to drive out retail competition, a charge that CVS flatly denies. Bottom line, the company allegedly boosts its profits by overcharging insurers for medications while often reimbursing pharmacists less than the cost of the drug, critics say. So I'll try to explain this. I was just reading about it. But basically, when you fill a prescription, if you're a Medicaid patient, basically somebody does have to pay for it. Okay, and I'm not. This is why I don't blame Medicaid people, Medicaid users for what's going on in it, because there is a real issue here that the industries and the bureaucracy cause that have made Medicaid this mushrooming cost monster. So basically, your insurance company is basically assigned to you by the state. You can basically pick from I think in Ohio we have 6 of them, and essentially they reimburse the pharmacy using money that they bill the state or the Medicaid program in your state. So that would be Ohio in my case. So it says here, as a result, retail pharmacies in the Buckeye State have been dropping like flies, and state regulators are looking at ways to bring more transparency to a Medicaid benefits management system that CVS dominates. Where I'm losing pharmacies right now is in high Medicaid areas, says Antonio Ciaccia of the Ohio Pharmacists Association. He noted that 165 Ohio pharmacies have shuttered in the past 2 years. Medicaid, the federal state health program for the poor and disabled, will spend about $3.2 billion on prescription drugs. So in Ohio this year, CVS Caremark, an arm of the company that manages pharmacy benefits. Okay, so this is the important part we're getting to. So CVS, which is one of the retailers, also has an arm of the company that manages pharmacy benefits. So it handles most of that money by billing insurers that contract with the state and then reimbursing pharmacies that fill patients' prescriptions. Ohio Medicaid Director Barbara Sears stressed, this is not an Ohio Medicaid problem. This is impacting all 50 states. It's a CVS Caremark issue, and it's not just impacting independent pharmacies. Sears said larger chains also have complained about reimbursement rates. Okay, so that's what we're talking about. That CVS Caremark, they have the ability to both sell it through their pharmacy and also to bill Medicaid and then reimburse other pharmacies and their own pharmacies for the same drugs. So here's where the abuse comes in. where you're feeding the money in, you know, they can just overcharge the Medicaid program, right? Then down the pipeline, when it comes to reimbursing the pharmacies, they lowball them. So they give them, you know, and we'll get to a pretty extreme case here. They'll do like a third of the actual cost of it, or even break even, which hurts the company, because you're wasting labor, you're wasting stock, you know, you're wasting stock space for this. Um, Inventory space is the word I'm looking for. Not only does CVS operate Ohio's second largest retail pharmacy chain, but CVS Caremark is the pharmacy benefit manager for 4 of Ohio's Medicaid's 5 managed care companies. So I missed that part, but so let's go back a paragraph. Ohio contracts with 5 managed care companies to coordinate healthcare services for 89% of Medicaid patients, paying them a set per member per month fee. The managed care companies hire pharmacy benefit managers, dubbed PBMs, which decide which drugs are covered, negotiate rebates with drug companies, and set how much pharmacies get paid to dispense them to the patients. So not only does CVS operate Ohio's second largest retail pharmacy chain, I'm repeating this, but CVS Caremark is the pharmacy benefit manager for 4 of Ohio Medicaid's 5 managed care companies. So that's that's almost a near monopoly there. If you're already you're a retailer and you're also a pharmacy benefit manager for 4 of the 5 managed care companies. Managed care companies would be the ones that are basically they're in place of insurance under Medicaid. Like Medicaid managed care companies, PBMs are supposed to save taxpayers money. Patrick Steffen, director of managed care for the state Medicaid program, said managed care and pharmacy benefit managers are saving Medicaid dollars. So he's basically, you know, being you know, playing the spokesperson. But the public doesn't know exactly how much of the more than $3 billion spent on pharmaceuticals goes to pharmacies and how much simply fattens PBM's bottom lines. Siacha said he suspects CVS Caremark is engaged in spread pricing, using one list with a low price to reimburse the pharmacist and another list with a high price to build a managed care program, and pocketing the difference. It's impossible to know exactly what's happening because the creation and use of such maximum allowable cost lists happens behind a veil of secrecy. He said the maximum allowable price is not an objectively defined and publicly available transparent pricing list, Siacha said. It is PBM defined and it is proprietary. Ohio House Finance Committee Chairman Ryan Smith, Republican of Bidwell, said that independent pharmacists are getting killed. Their rates are going down, but prescription costs are going up. It seems like the middleman is making out. So that's exactly what this created. Okay, you have Medicaid as a program. You have the managed care specialists. So those are 5 of them, and they have to you know, they have to disperse the funds to these PBMs. So the PBMs negotiate with the drug companies, and using the funds from these from a PBM, that will reimburse the pharmacies at the bottom level. Okay, so basically, there's 2 middlemen here. There's 2 middlemen between Medicaid as a program and the pharmacy. There's the managed care company, which is the insurance company, and then there's the PBM, which negotiates on behalf of the insurance companies the drug prices for certain pharmacies. And that's where they're getting cut out. They're getting cut out by the middleman, or that's where they're getting gouged. However, Siacha said the company's pharmacy operation. Okay, so CVS spokeswoman Christine Kramer didn't answer questions about whether the company engages in spread pricing. She did say that the company has measures in place to ensure that its pharmacy benefit arm does nothing to advantage its retail arm. So that's what it means, where they would be giving advantages to CVS's own retail, because they have their own pharmacies, because they could be giving a different price for their own pharmacies that they don't give to the independents. What do you think about that? There are strict firewalls between our retail business, CVS Pharmacy, and our PBM business, CVS Caremark, she said in an email. CVS Pharmacy has no insight into CVS Caremark's reimbursement of independence. So she's playing dumb. However, Siacha said the company's pharmacy operation wouldn't have to know what its PBM was doing to get an advantage out of the arrangement. Officially, they have maintained the firewall, he said, but it doesn't take a rocket scientist to figure out that, hey, over here on the PBM side, if we lower reimbursements to the pharmacy marketplace, then our pharmacy is probably going to benefit from that. They're going to be able to put people out of business. State regulators say they know how much they pay the managed care companies and how much they are paying their pharmacy benefit managers, but they have no idea how much the PBMs are paying pharmacies. Starting in July, Ohio is requiring Medicaid managed care companies to report how much PBMs are paying pharmacies to allow more transparency on prescription costs. So let me skip down. The pharmacists say it's clear to them that PBMs are profiting while they are losing money. What are PBMs pocketing? That's $1 million question. I guarantee it would make you fall off your chair, said one Columbus pharmacist who asked to remain anonymous because of confidentiality clauses in his PBM contract. So we get to the bottom. It says, Peoples, this is the guy's name. Hold on. Max Peoples, he's one of the pharmacists. He said, I'm staying in business because I'm praying and hoping it changes, but if it doesn't, I won't survive. People's provided several examples to illustrate the problem. In one, the pharmacy paid $44.61 for a month, so for a 1 month supply of muscle relaxant tizanidine. The PBM reimbursed the pharmacy $11.25 for a loss of $33.36. So they're losing. They're basically being paid 25% of the cost for a drug that they're paying for. They have to eat 75% of the cost on that. That's where the low-end pharmacies are getting it. If I've got the drug, I am obligated to dispense it, the pharmacist said. We don't have to stock the drug, but I can't not stock every drug. My patients need them. So he can say, well, I don't have that drug and not take the loss. But then how many drugs can basically you start to get edged out of different drug markets. That's what's going on here with Medicaid. So what is a PBM? This is from PCMA. I think they're a trade association. PCMA is it's a trade association for, here we go, Pharmaceutical Care Management Association. There's a national association representing America's pharmacy benefit managers. So pharmacy benefit managers reduce prescription drug costs and improve convenience and safety for consumers, employers, unions, and government programs. That's what they say. So they say that they do these things. They lower pharmacy costs for America's employers and consumers, protecting affordability and choice in Medicare Part D, lowering pharmacy costs for Medicare seniors, and improving safety with specialty pharmacies. In my opinion, that's really sort of a whitewash of what's going on. I have this from the healthcare blog, okay, and it's by Dana Elfin, and it's called "Independent Pharmacies Say Drug Middlemen Are Making Them Sick," and this is regarding the same issue. This from February 28th. It says, independent pharmacy groups in several states are sick of low insurance reimbursement rates that middlemen known as pharmacy benefit managers or PBMs pay them after drugs are dispensed, and they're pushing for greater oversight of the drug middlemen. PBMs include companies like Express Scripts Holding, CVS Health Corporations, Caremark, and United Health Groups Incorporated, Optum RX. And independent pharmacies say those companies' practices may threaten the survival of non-chain pharmacies. The PBM reimbursement rates and post-sale fees they charge pharmacies are challenging the survival of independent pharmacies, according to Alexandria, Virginia-based National Community Pharmacists Association, a trade association for independent pharmacies, more than 80% of which are located in small population centers. Moves are afoot in state legislatures, including Arkansas and Kentucky, to increase government regulation of PBMs. In Kentucky, for example, a state Senate committee approved a bill February 14th that would end state Medicaid payments to pharmacy benefit managers for managing the state program and let the state use the money to administer its own pharmacy benefits program. That doesn't sound like a bad idea at the moment. PBMs currently set all the rules with little to no government oversight. Kentucky State Senator Max Wise, a Republican, said in a statement, "As a state senator and taxpayer, I don't think that's right." In Arkansas, Governor Asa Hutchinson has promised to call a special legislative session on pharmacy reimbursement issues. Draft legislation circulating there would require PBMs to be licensed to operate in the state and give the state insurance commissioner rulemaking and licensing authorities over PBMs. But PBMs and others say these moves come with their own negative consequences. For example, state officials in Kentucky have said it would be significantly more costly for the state to administer the state Medicaid program itself than to have PBMs manage it. Similarly, increasing the minimum dispensing fee for pharmacies could cost the state at least $6 million. The Pharmaceutical Care Management Association, a Washington-based trade association that represents PBMs, sent in a statement that the Arkansas PBM licensing proposal would increase prescription drug costs without improving the quality of pharmacy benefits. The state should be encouraging market-based solutions to reduce drug costs, not giving special protections to the drugstore lobby, PCMA President Mark Merritt said in a February 27th statement. So then she says, read my full story on pharmacy reimbursement issues here. So maybe we'll pursue this later. I do want to say this, okay? There's several factors that are moving this issue in the wrong direction. One is the fact that this is basically, again, like the other story that I did in the other segment with the lead poisoning. This is a lobbying issue. This is an issue of programs that, when regulations go wrong, in the lead paint story, which just watch the other video from the day. You basically had lead paint lobbyists, the lead paint industry lobbying localities, municipalities, and whatever to institute codes that would mandate lead paint be put in homes, or sorry, in plumbing, in water conveyor systems, in water systems. So in this case, you have PBMs are basically a state mandated middleman that is basically a tool for corporate greed. So you have PCMA, which is a lobbying organization for the PBMs, blaming the pharmacist lobby for they're saying, oh, they're the lobbyists, the pharmacies, and the pharmacies are saying, what the fuck are you talking about? It's the PBMs, the PCMA, which is a lobbyist, and she calls it a trade organization association. They're both trade associations in a certain sense. Why is the PBM more of a trade association than the pharmacy association? It's really the same idea. And in my opinion, and this is where I am going to be a Chad. This is caused by, unfortunately, Medicaid being a program where the government says, oh, we are going to pay for everything. We're not going to make it government owned. But the government will pay for everything. Everybody, in this case, everybody in the program, not everybody everywhere, but we're going to pay for everybody who participates their drug prescription costs. Well, in order to do that under this system, you have to go through this middleman, the way they do it now, and they basically, this is a managed care company. They're basically in place of insurance, and then they have to go through another middleman to get to the pharmacist. And that's a major, first of all, the managed care programs, they make a lot of money themselves. And then you have the PBMs, they're charging a higher price from the managed care programs in the state, Medicaid, and then they're passing on those costs to the taxpayer. Okay. So you're being billed as a taxpayer. You're being billed more because the PBMs are billing more from these managed care programs. Then, in order to buffer their profits, they're reimbursing the pharmacies who have to actually disperse the drugs at a lower rate than normal, because for certain reasons, including what you just saw with CVS. So my solution, this is a tough one, admittedly. Well, one solution would be to do what Kentucky did, and that's to have it directly administered. So, the state would directly disperse the money to the pharmacies, and you wouldn't have that middleman at all. You would basically have the managed care company would, they would, but then who does the negotiation over the drug prices? And that's where the real problem is. When you're having this large pool of customers who don't pay, basically getting their drugs for free, and then you have these corporate interests that are basically you know, they're profiting off of that, then you're not actually having a truly representative healthcare system, because the prices are not capped. Okay, so these managed care companies, they can also, by the way, they can boost the costs of the coverage, and not just for pharmaceuticals, but for other treatments and products that are, you know, given by them. So that's first of all. And then you have the PBMs doing the same thing, and price gouging. And then when it comes to the producer of the actual product, or the disperser of the product, which in this case is a pharmacy, they get the shaft. They get the shaft for that free healthcare program. Okay, so there is a price to it. There is a huge price for free healthcare in this country, which eventually it would lead to either the corporatization of it, so you would only have chain pharmacies, and in this case you wouldn't have pharmacies in rural areas, because a lot of these chain pharmacies wouldn't want to operate there, or you would have people forced to adopt this government managed healthcare in order to provide for everybody. So you would, you know, in the worst situation, in my opinion, you would have a government takeover of the of the pharmacies and the care providers, because we're also talking about care providers here. In this case, we're talking about pharmacies, but think about clinics. Think about, you know, private clinics. You're talking about, and that's why a lot of private clinics don't want to take Medicaid, because they're getting lowballed. Do you want to get lowballed for your job? Because a private clinic, a private primary care clinic, you know, they have a lot of overhead. I mean, they might even have to be paying back their student loans, you know, 20 or 30 years later. So that's where I see this being a problem. So in my opinion, this is the natural result of Medicaid. Okay, yes, CVS is at fault because they work the system. They're also being a PBM while being a retailer, so it's wrong of them to do that. But Medicaid as a system allows them to do that. So please comment below if you have a different solution, or if you don't think that my criticism was correct. Please comment. You know, share this video, like this video, and subscribe to the channel. And have a great evening.